Good evening and welcome to tonight's webinar, Bridging the Gap, Strategies to Improve Physical Health Outcomes for People living with severe mental illness and severe and complex mental illness. My name is Gloria. I'm a mental health program officer on the Severe Mental Health and Psychosocial team at Central and Eastern Sydney PHN. I'm joined tonight by my colleague Christina from the CESPN events team. Jeez. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I'd also like to extend the respect to any Aboriginal colleagues joining us tonight. Please note tonight's webinar will be recorded and available on CESPN's YouTube channel within the next couple of days. If you would like to add any comments or feedback throughout tonight's presentation, please do so via the chat box. And if you have any questions, please submit these to the Q&A box. You can access both of these by hovering over the toolbar at the bottom of your screen. An evaluation survey will pop up on your screen at the end of tonight's event. Please complete this to allow us to issue you with a certificate of attendance. We have a number of CPD events coming up over the next couple of months that you can see on your screen at the moment. And we also deliver monthly CPR workshops. You can access further information and booking details via the QR code on your screen. We also have a number of general practice networking events coming up for practice managers, practice nurses, and also GP registrars. And you can get further information about how to book at the QR code on the screen. And please note that these slides will be included in the post-event email, so don't worry if you aren't able to catch the QR code at the moment. If you're looking for mental health supports for any of your patients, CESPN has a number of avenues to support with this. So the Medicare mental health phone line provides advice and support and can provide options around local services to meet your patient's needs. And the number is on the screen. We also have a Medicare mental health service, which is based at Canterbury. And this offers a safe space for people to find the supports that they need. As is mentioned on the screen, you don't need an appointment or GP referral for the service, and you can either phone the number on the screen or a patient can attend in person. And we're also in the process of establishing 2 new integrated mental health hubs, which are due to open mid-2026. So watch this space for further information about these services. If you're wanting to explore service options yourself, we have a service directory, and the link to that is on the screen. And as always, we have our health pathways if you're looking for clinical advice on any mental health conditions. So now I would like to hand over to our speaker for tonight, Dr. Kavita Seth. So Dr. Seth is sorry, stop sharing my screen. Dr. Seth is a senior consultant psychiatrist, addiction medicine specialist, psychotherapist, and senior clinical lecturer at UWA. She's the clinical lead at Fiona Stanley AOD service, principal psychiatrist at Street Doctor WA, working in Aboriginal health, and has also worked at Dokotela since 2018. And we are very happy to have you here tonight, Dr. Seth. So thank you very much.
Thank you, Gloria. Can you hear me, Gloria?
Yeah, I can hear you and see
Well,
see your
good.
slides. Thank you.
Okay, thank you. All right, welcome everyone to this session, Improving Health Outcomes for People Living with Severe and Complex Mental Illness. I know we have quite a good proportion of them in our clinical practice, whether we are a GP or allied health. and it is quite a complex situation, especially trying to navigate them to the appropriate services, so they get the best possible care holistically in a public care setting can be very challenging. So I hope today's session will give you some pointers to manage your patients in your day-to-day practice. Without having much heartache in your practice day to day. So today we will be talking about learning outcomes, the principle of biopsychosocial model, which I always use even regardless whether they are complex or not. I think, and it works very well for any illness, whether it's medical or mental health. And I'll go through with you all the principles of it. Sleep is a very, very important aspect of mental illness. And that will be the number one topic that we'll be discussing about. And then comes lifestyle modifications like healthy diet, exercise, smoking, alcohol, and other drugs, some psychosocial interventions and social interventions. And when we have someone complex and still struggling, we need to sort of ascertain what sort of symptoms they are still struggling with, and have the right pharmacotherapy without causing too much of polypharmacy. So we'll go through that as well. And then lastly, despite having all types of treatment, what do we do for those who are poor responders when it comes to mental health treatments? Okay, so quite a full-on session today, which I will slowly go through, and I'm more than happy for any questions at the end. Please put it in the chat box, or once we are open for questions, you can unmute and ask them. Okay. So relevance to GPs and also allied health as well. We are, the frontline specialists managing mental health and physical aspects of the patient. Like I said, whether they have mental illness or not, we need to understand, after treating them assertively, actively, what are the negative symptoms that they have, or the side effects of the medications that they have, and the residual symptoms. Many a times we do give them high-powered medications, and we weigh the risk and benefits. And once they have gotten the benefits of the medication, what are the residual symptoms left, or the negative side effects that we need to think about in the post-treatment phase, and how do we manage them? And to manage everyone holistically in the biopsychosocial model, I always tell my patients and also fellow colleagues that each aspect is equally important. 33.3333% each. Bio management, psychological management, and social management. Not one is more important than the other. So once we get a good balance of the biopsychosocial sections, then we can, look at the patient and sort of manage them ongoing in a very holistic manner. So I'll explain all of that in my slides. Okay. So the number one is the biosocial model, psychosocial model. Is an integrative approach. It considers the three important aspects of a person's well-being. Okay, so biological factors, what are they? They could be familial history of mental physical illness, what's their neurobiology like, whether they have neurodevelopmental disorders like autism or ADHD that is complicating the picture, and whether they have any physiological processes. So, for an example, subtreated diabetes because of non-compliance or subtreated high blood pressure. These things can still perpetuate mental illness, as we know. And we need to consider how the other diseases and physical conditions can influence the mental health, or the mental health can influence the physical conditions. So we need to make sure that their sleep or their weight, any drug and alcohol, and any medication is complicating the picture, and sort of holistically manage the medication point of view. Now, when it comes to psychological factors, we need to understand what the patient is going through, what they have been through as well. Childhood trauma that is perpetuating some personality disorders. So, despite all the treatments that we have given for antidepressants or antipsychotics or sleeping medications, do their mental health condition still perpetuates because of past trauma, where little triggers or flashbacks are still triggering them and keeping them subtherapeutic and still having symptoms. So if that is the case, what do? We will discuss that in a bit. And as COVID has changed our platform of treatment, now we can even incorporate digital psychology as well for rural, remote, or patients who find it really hard to get about around and see a psychologist. They can use digital or even apps as well, which we will talk about in a bit. All these are very, very useful for patients, especially when we have the chronic complex patient that is not working, not much of social supports. Having these sort of digital apps and all can keep them well informed and also augment their treatment. At the same time, we do not want them to be homebound all the time, and and sort of give them a lot of digital treatment and nothing on the outside, like a good sunshine or meeting the therapist in their office. So we need to weigh it up, okay? And also cost is an issue as well, which I'm sure the PHNs will talk to, have well informed you guys time and time on what are the available services out there. Then comes socially. We humans are not born to be isolated individuals doing everything on our own. It's very important to include some social activity. And that's when I do advocate for things like NDIS support, where they have a support coordinator that encourages them to do some kind of group activity or group therapy, or getting out and about, managing their ADLs, activities of daily living and finances, budgeting, shaping their own health behaviors, access to care. Okay, so all these three are very important, and please always remember these. So when you have a very complex patient in front of you and they are, making you feel a bit despondent, a bit demoralized, please break it up with them, biopsychosocial, and try and focus on each of them and try and come up with a holistic plan. And I'm very, very sure they will leave your consult room better than when they came in. Okay? We need to instill hope in our patients, and ourselves as clinicians as well. Now, sleep is very important. As you know, if one doesn't have good sleep, even for us without mental illness, we will deteriorate. Okay, we will get a bit moody, a bit irritable. We don't really fare well. We get sick quite easily. Our immunity goes down. So you can imagine those with a vulnerable medical and mental health composition, on how it will affect them, especially when it comes to psychosis, depression, and mania. Sleep is the number one first line treatment that they need to have well treated in order to maintain good mental health. Okay, so, and it's very simple to discuss and manage. I know the medications. I will talk about a few pointers that we have developed in Dokotela. I'm sure those who have access to our WhatsApp group, the general practitioners, they would have had Dr. Mastek a few months ago posted something about sleep, which I thought was very informative. So I've got a slide about that in the next few slides. But it is very important. I can't emphasize enough on the amount of importance sleep has on the complex patient. Okay, complex or not complex, on our patients. They need to have really good information, really understand what sleep, how sleep is important to them, the diurnal circadian rhythm. A lot of our complex patients have nothing going on in the daytime, which is really sad. So they sleep really late, early morning hours, and then they wake up mid-afternoon. They do get their 8 hours of sleep, but if it is not according to the circadian rhythm, they are not in their optimum health. Okay, so it is very important that we address that, and we address it vigorously. So we ask them in the appointments on after giving them, like, some good sleep apps. The websites are here. These are all reputable websites that are being endorsed by the Royal College of Psychiatrists. So we give them that information, some apps, of course a bit of medication, and talk to them about diet and lifestyle. We need to find out what is the real barrier in applying that kind of information in their day-to-day functioning, and try and address it. Sometimes we need a lot of motivational interviewing, because they try for 1 or 2 nights and then they can the whole idea and say it's all too hard. We need to personalize it as well. A lot of our patients are always on the phone. Sometimes we are also culprits as well, where we are always checking messages, texts, or social media just before going to bed. The kind of blue light is not really great for our eyes, and it also keeps our mind stimulated, and there's really no shutdown period. Um, we need to make sure that there are the practical aspects about the environment is conducive for sleep. We can't really, we confuse the brain. For an example, if we are using our bed to have our work laptop on our lap, and we're sitting up in bed and we're doing our work, and then using the same bed for sleep, we need to train the bed that the moment it sees the bed, it's pairing that it's meant to be sleeping now. So we need to, an hour or two, dim the lights or reduce the noise, turn off the TV, have a bit nice shower, warm shower, make the bedroom temperature good, 22, 24 degrees, or whatever is our liking. Sometimes patients do say the heavy blankets are good for them as well, because it really does give them some warmth and some comfort. for sleep. Some use lavender oil and aromatherapy. All these things need to happen an hour or two, where we are starting to tell our brain, okay, now we are shutting down and we're going to go to sleep. And if at all we are the constant worriers, then it is good to have a notebook with a pen, for an example, where we can write down 5 things before sleeping on what is it they're worried about, and try and address them as you're writing it, so that we can pack it away and it's time for sleep. Okay. And I like This Way Up. It's a really good online CBT, free online CBT insomnia program, which does very comprehensive sleep hygiene techniques. And I have been using sleep physicians quite a bit, especially for those that are very, very resistant to sleep medications and techniques. We could, in the general practice, talk about sleep apnea and CPAP machines, for an example, because many of our medications do put on the weight, unfortunately, and that can predispose one to have sleep apnea. So it is important to involve the sleep physician, or have a sleep study as well. Okay, so that is the sleep techniques. These are some medications that we have used, that are common in our practice, but we need to make sure that it is time limited while they get good techniques in, things like benzodiazepine, the Z drugs. We don't have trazodone here. I think it's in the States, in America, but the Z drugs, like zopiclone, zopidem, those sort of medication, they can be they can be abused quite high. And I do tell patients that long-term use, they kind of step it up, because the same dose is not going to quite cut it over a long-term period. And that can actually predispose them to have really slowing of neural activity, and therefore predisposed to dementia. They get very forgetful quite fast. So I try and explain that these things are not that great. Melatonin is good. Patients do say that they wake up with headaches and dizziness sometimes. Melatonin follows, it's a circadian hormone, right? So we need to take it much earlier. I tell patients take it about 5, 6 p.m. because it does take quite a long time to kick in. And sometimes it takes up to 13 hours to clear the system. Even quetiapine and benzodiazepines, I tell them to take it much earlier, about 5, 6 o'clock, so that they can start winding down and go to bed by 8:39. Many patients do a huge mistake by taking sleep medication when they want to sleep, and they can take it as late as 10, 11 o'clock, hoping that they will wake up fresh at 6 or 7 a.m. Does not work that way. The medication can last in the bloodstream for up to 12 hours. So we need to tell patients that when they are on some sleepers, it needs to be much earlier. And then you've got really good tools like, the online CBT modules, low dose of doxepin, or I use amitriptyline, doxylamine, or valerian. But as we know, any sleep medication does cause tolerance over time, and it's just for short lived. We can't be using this for years and years. It does cause long-term effects, like I explained. Okay, mainly dementia, forgetfulness, tolerance, addiction. Stopping benzodiazepine suddenly can cause seizures as well if they are on high doses. Okay. Diet is very important. Very, very important that they have good diet in their lifestyle. none of these fatty foods and all. We need to explain the food pyramid or refer them to a dietitian if we can. Fruits, vegetables, nut and seeds are very important. Fresh rather than processed food. Anything to do with meat must be lean fish, meat, dairy, low fat, especially those who have medications that make them put on weight, to have them in moderate amounts and reduce saturated fats. Oil needs to be healthy. Of course, alcohol needs to be moderate. Alcohol reduces the REM cycle, rapid eye movement cycle, and we have patients that when they even have 3 or 4 standard drinks in a night, they can get maximum 4 hours of sleep and they wake up really, really hungover. But, which is due to poor sleep and the alcohol effects, headaches and tiredness and loss of motivation, apathy, slow movements, irritability, headaches. Alcohol is no good. Even though it says in our national health guidelines, 1 to 2 standard drinks per day for males and 1 for females, I do tell patients have a few days of non-alcohol days and do not go more than 4 standard drinks in one sitting, because alcohol, you can imagine when we have that amount of alcohol, especially the binge drinkers of our patients, when they're bored, they try and fill that empty cup inside and they fill it up with alcohol. They wake up hungover every day. And imagine the impact of this constant hungover feeling. It does deteriorate their mental health, no doubt. So it's very, very important that we address alcohol because, it's just there. It's there here, everywhere. During festive seasons, buy one, get two free in their local liquor store. It is a real problem. And alcohol also interacts with our medications, especially antidepressants, antipsychotics, making it ineffective. And alcohol, especially too much alcohol with benzodiazepine or quetiapine or the Z drugs, can cause respiratory depression risk and accidental deaths or strokes. So it's very important we address it. Alcohol, it is a very big depressant. It is a depressant. I tell my patients, because I'm an addiction psychiatrist, I tell them it feels so right at that time, but it's momentary. The depression, the depressive mood and the anxiety that follows the next day, it's not worth it. And then comes, having good probiotics and omega-3 fatty acids. There's some research about microbe in our gut, influencing our mental health. Even I take a probiotic. It does no harm. And there is some good research emerging on how it does help. And certainly no caffeine after lunchtime. You'll be amazed how many of our complex patients on polypharmacy medications, sometimes a depot, plus an oral antipsychotic, plus a sedating antidepressant, they have Red Bulls in the morning to keep awake. And that just perpetuates their insomnia at night. It does not do them any good. To have many of our patients have this constant cycle of having a sleeper at night and a Red Bull in the daytime. It defeats the purpose. And I tell them they need to cut down the caffeine. And if they train their brain, after some time, their body will sleep. So it's so important. It's so important. I can't emphasize how important it is because I have patients waking up and having a cup of tea or having a cup of tea before bed. How are they going to sleep? I mean, anyone can wonder. So we need to educate our patients. regular exercise is very important. I tell my patients if they do enough of cardio and strength training, they will inevitably tire their body out and get sleep. So it's very, very important adjunctive treatment to our patients who have chronic depressive psychotic disorders, and that feel good hormone, that natural endorphins that hit us after a gym workout, or even going for a nice walk or a jog around the neighborhood early in the morning. It does us so much of good. And it improves our self-esteem, improves the sleep quality, and also interactions with others. Daily exercise is preferred, at least 20 to 30 minutes on our heart health. We can't go wrong. Aerobic exercise is good. If they don't like weight-bearing exercise, especially our overweight patients or the older population where their knees are giving way, they can enroll in their local council pool and even walk up and down the pool. I tell them it is such a good exercise to walk up and down against the resistance of water. They will build muscle and it is less weight bearing. Okay, so it is very, very important. And resistance exercise is good as well, especially as we get older. Our bone density will get better if we do a lot of strengthening exercises, not only for our patients, but for us as well. And it is important that we talk to them. There is lots of good exercise apps that we can use, and in these apps they do have motivational quotes that you can get your patients to access. And it needs to be pleasurable, not exhausting. They can always start slow. They can start in low intensity and build up, and over time, they will find it like a routine. Because I tell them it's like brushing your teeth every day, to have a good routine and to keep their fitness and their heart health good, and document it as well so that we clinicians can see what they have done. And it's a really good visual motivation, and we can praise them as well. Those with depression, lack of motivation, especially the antidepressants and antipsychotics that slow them down, we can talk to them and say, go for a walk, even if it's with a family member or a bestie, or even with a pet. I've always encouraged patients, if they can, to actually get a pet. Emotional support, and having a pet will improve their lifestyle, get them up and about, because, they are forced to take the pet for a walk or be with them. Um, there are a few websites there and a few good apps as well. Victoria Health has got a really good health related apps. If you go on their website, which is there in the website suggestions just at the bottom of this slide, please use them, and they are very, very helpful. Okay. Smoking. A lot of our mental health patients are still smokers, which is really sad, but that's what it is. We It's very interesting because sometimes the medications that we give our patients, especially antipsychotics like Abilify, for an example, that can increase restlessness, or Latuda, for an example. Certain antipsychotics, antidepressants can increase restlessness. So patients who are smokers tend to smoke even more, because they're constantly needing to move. So sometimes while we are treating something, we increase the risk of something else. So it is very important to check on how much they smoke, especially those who smoke just before going to bed, where they have a couple of cigarettes with their coffee or tea, and then they say they're not sleeping well. We have so many of them. We have so many of them, and it's very important to talk to our patients and discuss how smoking compromises their medical and physical health. And having, I tell patients to put a patch on. They can still smoke, but at least it reduces the smoking, or to have something like nicotine replacement therapy in the form of inhalers or lozenges. Okay. Vaping has caught on quite a lot. I don't really like vaping because it does damage the lungs as well. I mean, it is less, it's lesser of both evils, let's say, let's put it that way. But having the pharmacy board NRTs are better, the nicotine replacement therapy, to discuss some behavioral strategies, like exercise, relaxation, distraction, rest, have some medications that we can use. I use quite a bit of bupropion, which is Zyban, because it does have a really good added benefit of being an antidepressant, and it's also good for ADHD patients as well. And it's also useful for smoking cessation. It is on the PBS for smoking cessation, though it's time limited. But if the patients do find quite a lot of good benefits with it, they actually do spend that amount of money to continue on bupropion. Champix varenicline is effective, but please be careful with those with depression and psychosis. It is very important. I know a lot of my addiction medicine colleagues use it, but I try Zyban first, bupropion. If you want to do varenicline, it is quite effective for smoking. You need to keep a close eye on them. And also to have apps or a quick date or a quick website, the one listed here is good. We need to keep talking to our patients about smoking. I know sometimes we feel like they are complex and chronic, and that's the least of their worries. But if they are having cigarettes late at night, especially together with tea or coffee, that's not going to help their sleep, and therefore spillover effects on their mental health. Okay. And that brings us to alcohol and other substances. We did talk about alcohol. I will talk about other substances like cannabis or methamphetamines. Patients are using more and more of GHB, which is the equivalent of a benzodiazepine. It's a small liquid that is highly potent, and it can cause accidental overdoses. It is important that we do address illicit substance use. As an addiction psychiatrist, I do not advocate patients to be on cannabis or medicinal cannabis. However, I do talk to them about harm minimization and trying out CBD oil or using the CBD flower that is 0% THC. And I think that's okay if they feel like they need the cannabis to mitigate residual symptoms like restlessness or poor sleep or anxiety. I usually combine them with a low dose of quetiapine, for an example. Okay, so substance use is very, very prevalent, especially amongst our chronic and complex patients. And we need to gauge the readiness for change as well, because it's no point talking about addressing things like alcohol, drugs, smoking, exercise, diet. If patients are not really ready to change, we need to always try and do motivational interviewing and try and work through the stages of change, from move them from a pre-contemplative to a contemplative stage, for an example. Okay. And there's so many pointers here in the websites that we can use and work through with our patients when we are doing their complex care management, for an example. So the lifestyle, especially for mood and anxiety disorders, good nutrition, probiotics, exercise. Okay, they are all really high levels of evidence, and we can't really discount it. We need to talk to our patients about incorporating them. And that is when, things like NDIS is good because at least we can have a case manager that will say, okay, come on, John, let's go out, let's take a walk around and have some salad, for an example, or go to the local pool. And the moment we are in the waters, we feel good, and that should be their daily routine or almost daily routine as well. Okay, some good social supports. Okay, I've talked a lot about NDIS. We need to try and ascertain what's a good social support for our patients. Do they have good family or good mates? Can they access some local networks like for DVA clients? Open arms, DV victims. There is a lot of local social supports that we can access. Try and get a list of your local area so that you can put some pamphlets, at the waiting room, so that patients can access. And that sort of, will keep them going, I believe, like a Tuesday bingo night, for an example. That really does help their mental health, and it keeps their interactions with others healthy rather than being cooped up at home, no sunshine, no daylight, just them and the TV and the computer and the phone. That doesn't do well on their mental health. And we need to encourage them each time and try and see if we can get good case managers for them. And I can't emphasize enough on your local area and having some good pamphlets at the waiting room. That really does have a big impact. Um, in our local mental health team, for an example, local council, for an example, we do have like some mental health day on a Saturday afternoon or a Sunday morning, where we do some education talks to the local population. I'm in WA. Sadly not from your PHN, but I'm involved in those education, and we have a barbecue, for an example. We try and encourage the patients to be a bit more active in their local area. So some online clinics or for us to get some information. This slide is about some psychological online free help that we can give our patients. Psychology sessions are quite expensive, unfortunately, and our complex chronic patients can't afford. Try and find out what is available in the PHN and in your local area. I always tell patients that they can always add on online plus a face to face if they, especially the free sessions, they do It's not as frequent, and it does come like once in a fortnight if we are lucky, or even once a month. They can always add on some online CBT, and some apps as well for their psychological well-being. Okay, I do like this way up quite a bit. Mind Spot is good as well. Um, Try and go through them yourselves. See what is it that you feel will benefit your patients, and then talk to them about the psychology treatments that they are receiving, or what you can share with them. Okay, this slide is all about some residual symptoms that patients might have, especially if they have anxiety or restlessness. Do we augment with a SSRI or an SNRI? I know a lot of patients who are on ADHD medication, for an example, they do get a bit of anxiety from the stimulant effects. We do augment with SSRI. Um, Sometimes we need to give patients non-sedating antipsychotics that can cause anxiety. We can augment it. For those that can afford, vortioxetine, Brintellix is really good, least amount of side effects. For those with cognitive difficulties, you can add on duloxetine. As you know, a lot of our pain specialists, they do like duloxetine as well. And I tend to combine duloxetine with a small dose of amitriptyline, and that seems to work for anxiety and insomnia. For sleep disturbances, mirtazapine is there. But look, if we are going to add on olanzapine or quetiapine with mirtazapine, they're going to put on 40 kilos. So try and see what your patients can suit. Agomelatine, I've always seen only a 50% success rate. If that, I'd rather give low dose clonidine. As you know, it is a really good calming medication, catapress. Clonidine is good for the young ones, the kids. It's also good for adults. And guess what? Sleep physicians are using it for pain as well. So, for our patients with complex chronic mental health, physical health issues, we have a lot that come in with back pain and knee pain, for an example, or fibromyalgia. We can use some clonidine. For fatigue, I have found Zyban good, bupropion. The pain as discussed. For those with melancholic depression, what I mean by that is those that wake up feeling extremely low in mood and then feel a tiny bit better during the daytime. Psychomotor slowing or apathy or lack of motivation. That's all part of melancholia. TCAs are quite good. Amitriptyline, nortriptyline is quite good. Um, and those with psychotic symptoms, we do antipsychotics with a tiny bit of antidepressants. And for those who have atypical symptoms, MAOIs are quite good. But try and be for those with complex and chronic mental health, if you're worried about them misusing their medications, always Webster pack. I Webster pack for all my patients that I find may or may not be compliant or may overuse. Um, they get weekly supplies from the pharmacy. I know it's a bit expensive, but I do encourage GPs to ask for Webster packs. Okay. Some side effects of our medication can cause, poor sleep, and can cause cardiac problems or weight gain or sexual dysfunction. This slide is you can choose what sort of antidepressant you would like to give your patient to mitigate some things. I know a lot of my patients tell me, I don't mind what you give me, I just don't want to put on weight. Then I would choose the SSRI, SNRI, agomelatine kind of antidepressant. I have my mining clients, I mean WA, that with all the truck drivers that refuse to have anything that's sedating. Then you choose your less sedative antidepressants. For those with fewer cardiac side effects, we know that TCAs can cause cardiac problems, longer QTC intervals. So we go for SSRIs mainly. And for sexual dysfunction, Zyban is usually the best, or even Vortioxetine, lesser sexual dysfunction. So just tailor your medication according to the patient needs. RTMS ECT. Okay, I'll talk about RTMS first. Transmagnetic stimulation is there. There's so many pockets of them. Clinics are emerging everywhere on that are bulk bill, Medicare rebatable, no out-of-pocket expense, and it does show some good outcomes. And whether it's because the patient sees a therapist Monday to Friday for 4 weeks and they feel very supported and therefore they feel much better, we still don't really know, or whether it is the actual stimulation, non-invasive, every day, for half an hour or so. We don't know, okay? But it does show some promise and is no harm. Doesn't cause memory loss like ECT would. So I would encourage patients who are still have residual depression despite the treatments that you have offered, biopsychosocial model, to think about TMS. Okay. If they are quite depressed or they're becoming quite depressed, poor self-neglect, do flag them with the local mental health team. If they can afford private health cover, then do refer them to a private inpatient psychiatrist, and they might be able to do ultra brief unilateral ECTs. I have seen a lot of good outcome with that. Even for patients with severe EUPD, borderline personality disorder, chronic dysthymia, almost like a treatment-resistant depression and constantly debilitated with the impulsivity and self-harm, I have seen ECT quite good, but it needs to be ultra brief unilateral to not a huge dose of ECT onto them, that doesn't impact the memory as much. For those with severe depression and psychotic depression, of course, ECT is a preferred option compared to TMS. But TMS don't discount it and try that if you are really stuck with your patients. And managing poor response. Okay, so despite everything, they are your heart sink patient and they come into the clinic and they are wondering, what else can you do? You have listened to this session, you've done everything you could. Biopsychosocial model, try and see if compliance is an issue. I have a lot of patients that do forget their medication or take it as and when they want, like a PRN. antidepressant, antipsychotic like a PRN. It doesn't work that way. So we need to talk to the patients. Okay. Ensure compliance like Webster Pack. Try and encourage them to bring a significant other in the next appointment, so you can talk to the significant other on how else you can implement the biopsychosocial model. If they're eligible for NDIS, which almost all of our complex chronic patients would be, try and get some NDIS support. It's not too hard. Even if the patient or their family member engages with the local NDIS, they actually can start the process for you. And you just have to book the appointment and just fill out the forms. It's not too hard, especially when you know the patient. I thought it was onerous, like 8 pages, but actually, when I sat down and did it, it just came out of my head because, I actually know them and I know what they're struggling with. So mobility or social interactions and things like that, I actually knew what to write. And sometimes if the NDIS worker is there, they could actually, some of them actually come into the appointment and sort of guide us on how to write it so that they get the best package possible. Try and review your polypharmacy medication as well, because there could be side effects and interactions that they are trying to mitigate by smoking too much, drinking too much of Red Bull, trying to stay awake in the daytime, but not enough of sleep at night because of all that smoking and Red Bull and tea and coffee. So try and look at it in the bio model about the medication and compliance. Check whether they are seeing a psychologist or are they using any apps, diet, lifestyle, alcohol, and then see what social clubs they can do. They can join, encourage the significant other or group of mates or local gym or the pool, that sort of thing, try and encourage them in that way. Check the My Health record because or script check. You'll be surprised on how many of our patients see other GPs because, sometimes we are booked out, for a few weeks and they see someone else and then they get a script of something and then they are on something new added and you don't really realize and you assume that what you have is current. Do check it. You'll be surprised sometimes. Don't forget the biopsychosocial model. That's my, if there's anything that you could leave here today as a take-home message, if you break it down, you will see how simple it is, and try and implement each stage with them, and have as regular a follow-up as you can, or try and engage someone like a case manager, support worker, for an example, the DV or the trauma victim support or open arms with DVA, whatever support systems that you can put in place so that someone is able to follow on from your advice and you can check in with the patient, would be my advice from today's session. Okay. We have another half an hour and I'd love to hear any comments or any questions that you would have. Please type into the chat box, and I'll be more than happy to answer them.
Thanks for that, Dr. Seth. That was great. We do have a couple of questions in the Q&A box. So I think
Yes.
they both refer back to the beginning of your presentation when you were discussing sleep, which I know is a really important component. So the first was around the best medication,
Apart from melatonin.
other than melatonin,
Yeah,
yeah. What
I
would be
just see that.
the
What is the best medication with least weight gain apart from melatonin? I would say, and that will be in the follow-up in the next question on clonidine. I'll say clonidine is really good. Um, the problem with melatonin, like I said earlier, was many patients just take it half an hour before bedtime and it's too late. They need to take it at least 5 or 6 o'clock to kick in with their circadian rhythm. Clonidine is good. We need to bear in mind with clonidine, it does drop the blood pressure, especially among our younger women, and those with POTS, for an example. So we need to just be aware of that. But clonidine is good. Try half a tablet, and if it doesn't touch any sites, the patient can have one. I have a lot of my patients on that on the 150 microgram tablet, and sometimes they combine it with melatonin, like many young kids do. The pediatricians do recommend sometimes having melatonin with cataprest together earlier on in the afternoon. Okay. Um, that's really good with the least weight gain. Sometimes I have patients on the TCA, like low dose amitriptyline. I know higher doses can cause weight gain, but low dose 10 milligrams to 20 milligrams of amitriptyline does not seem to cause that much of a weight gain. Um, so that's something else that I do recommend. Another thing that I recommend, and that is, of course, if patients can afford, is the Belsomra. Belsomra seems to have given some good benefit without weight gain and addiction. The Dayvigo, Lambroxan, I think it's called. Um, that's also another um that's also another newer medication, but of course, it comes with side effects. Sorry, with cost. No side effects, sorry. I repeat, it comes with a huge cost. Something like $60 to $80. So that is what I would see my patients having when they have trouble sleeping. Another best medication could be a CPAP machine. So it is important to have a sleep study as well. Um, okay, we have another question there. Gloria, we just need to put up some local services slides.
So I think I was just referring, going back, I think a few slides, you had a table of different services. And just to let everybody know that
That will show you the patient. Please
a
put up
copy of
the local
this,
service slides that will show. Oh yeah, so Gloria, you'll be sending the
yeah,
PowerPoint to everyone, right? Yeah.
yeah. And there was,
Vyvanse. Okay. Vyvanse it is very interesting because 50% of our patients sleep so much better on Vyvanse. And then the other 50 say it's too they have trouble sleeping. And that's because sometimes it goes beyond 12 hours for them. So we need to we need to review the dose. Is it too high? And whether do they need a shorter dose, like a smaller dose, like 20 milligram, where it sort of like finishes by 2 p.m. and then some psychiatrists like myself add on 1 or 2 dexamphetamine so that it leaves the system quicker. So if you know what I mean, Vyvanse is meant to last for 12 hours. On a smaller dose, it does last shorter, even in larger doses as well. Eventually, it all, the duration goes shorter and shorter, but it eventually stops at about 2 or 2:30 p.m. where the patient becomes a bit more tired. I usually add 1 or 2 dexamphetamine short-acting stimulant where it lasts for another 4 hours, and then they tend to find good sleep, or whether they need to be just on short-acting dexamphetamine, 1 to 2 tablets twice a day, morning and lunchtime. That's something that the psychiatrist can revisit. Or do they change to Ritalin, 1 or 2 tablets? So it is a very interesting scenario because while you have a lot of patients being treated for ADHD, they do report good sleep. You do have another proportion of them saying poor sleep, most likely because it is long acting and it's still there even during bedtime. Even though the effects of Vyvanse would have finished by 2, 3 p.m., it's not quite cleared the system and they are still sensitive to that tiny bit that is still there at 10 o'clock at night. So whether they need a dose titration. Medications regarding sleep, there was intervention labeled CBTI. Yeah, so that is the online CBT. That's right. That's part of the psychotherapy, cognitive behavior therapy that's online. Um, and and that's the different apps and the websites that the patients can access. Whilst we don't encourage them to have fully psychotherapy online, which doesn't get them out of the house, especially the chronic complex patients, um, it is important that they supplement it in between psychotherapy sessions. So in our
We
webinar
have,
chat, we've got
yeah, I was
another.
going to say there's a couple of questions in that as well.
I have seen clients who have been given Zyban and it causes changes in behavior, such as gambling, risk taking. Have you seen that in some patients? Look, that I would never say never. It can happen because it is not sedating, it is quite activating, and that can happen. It's quite rare, but that's the initial phase where we need to monitor. On the other hand, it does help quite a bit in terms of energy and smoking and depression. So you're right. We need to monitor the side effects of Zyban. Mm, could we use daytime for anxiety and MAOIs? Yep, SSRI in the daytime, MAOS. I don't combine it that way, but I do SSRI in the daytime or SNRI in the daytime and a bit of TCA at night. Um, like amitriptyline. It's one of my favorite because it helps with sleep, it helps with depression, it helps with pain at night. Insomnia in dementia patients are very tricky because um they are a bit older. Sleeping medication can reduce their blood pressure and cause falls. I know a few psychogeriatricians that use sedating antipsychotics like a tiny dose of olanzapine or quetiapine. Um, but we need to be very careful with the dementia patients, because most likely the dementia patients themselves are not coming to you saying they've got poor sleep. It's the family around them that says that they're up and about at night and really active and sometimes leaving the house and going into a different neighborhood and that sort of thing. So then we need to rethink on with ACAT assessments and things like that, okay? And whether they need a bit of placement if things are getting out of hand. Um, you would need to also try and mitigate those lifestyle changes as well, that they don't drink cup of tea or something like that before bed, that many of our older patients do. Tea with biscuits before bed. We don't want that. They get very sensitive to the caffeine as they get older. Um, and their medications, whether the medications that they are on causes poor sleep. Many of them do. So whether do we rationalize it, and then a very low dose of, they have melatonin or a little bit of clonidine. Of course, bear in mind the blood pressure side effects, hypotension, and also whether they can tolerate a tiny bit of quetiapine or olanzapine. Um, I purposely did not say risperidone because they do make Lewy body worse, especially if you don't know what kind of dementia they have. But that's something that you could refer them to the psychogeriatrician, or have CT brain or MRI to rule out any of that. But those would be the sedating medication, because you're not really worried about weight gain in a dementia patient. You're more worried about keeping them comfortable, like, and keeping them, and having the best quality of life that they can have in their remaining time. So these are the medications that we will try them on. Sometimes low dose of benzodiazepine, like, at that age or at that stage of their illness condition, whether are we really worried about addiction and dependence. So these are the things that we would use in a nursing home or in the ward. And if they are cared for by family in their own home, you would have that. Um, or if things are really getting out of hand, where they have poor sleep and therefore increase in the behavioral and psychological symptoms of their dementia, and they start getting irritable, angry, lashing out, and becoming a bit psychotic or paranoid, stemming because of poor sleep, then we really need to think about placements at that time.
Mhm. I just had a quick question as well. We've addressed all the questions that have come in so far, but I know we have a bit more time if anyone else has questions. But in the meantime, I just had a quick question around how would you recommend approaching kind of that discussion around lifestyle? Because I know for anyone, if if your mood is low and your energy levels are low, you're not going to be particularly motivated to, exercise, and you might be more inclined to, eat sugary food or, have some alcohol to help relax and stuff like that. But how do you kind of frame it, I guess, with the bigger picture in mind around,
Yes.
um,
And which is what I was saying earlier. Motivational interviewing is very important, that they roll with resistance. They try and hear from the patient what is difficult about
mhm,
implementing these things. And if they are really complex and chronic, they will qualify for NDIS and have a social work support worker to come and bring them out of the house. Whether they have loved ones that will come back from work and say, all right, come on, let's go for a walk or a bike ride, or whether they can go for a swim, or that sort of thing, or have mates. Do they qualify for local services where they can join a support group?
mhm,
And like, for an example, open arms, I was saying, in DVA, or have, like, in WA, there is Luma mental health services, where there's a lot of support workers there as well. If it's really difficult on their own, then firstly we need to really look at their medications and see what of it is could be sedating them in the daytime or taking away their anxiety, taking away
mhm,
their motivation. Are they using cannabis quite a bit? Do they need to change to harm minimization, lower THC, and then finally just CBD oil or flower through a medicinal cannabis website?
mhm,
And also, their support area, support structure around them. Because I do agree that those with complex and chronic mental illness, they will find it really hard. I also forgot to mention the perimenopause patients as well, to please consider doing, hormone workup as well, because sometimes that complicates the picture even more, where their hormones are going out of whack, and then they have got low energy and poor sleep and irritability and up and down moods and up and down appetite, on top of their chronic and complex mental illness. So that's another thing to consider as well. Is the biopsychosocial model. If you have someone that's coming to you and saying it's all too hard, I just can't do it, I can't eat right, I can't sleep right, I can't do any exercise, then just think of the medications that they are on. Do we have to change? Do we have to alter it? Do they need to see a psychologist? Do they need to have some social supports? Accessing NDIS is extremely difficult with the budget cuts. And that is why I was saying that, well, I mean, in WA, I work with NDIS coordinators that give me the right words to put on the application form. Yeah. And they actually know what to say. They are well trained in this field, and we have the best of intentions, and we put everything in there, but sometimes without the right format it gets rejected. So my thoughts would be to actually, if you have a good practice, to actually get a practice manager to invite one of the case managers to of NDIS to come one day for a lunchtime and just give you all a talk, and then leave some brochures or some information where you can use it for those who have chronic depression, treatment resistant depression, autism level 2 or 3, chronic schizophrenia, and actually have a few keywords there that you can use with your local NDIS providers.
Yeah, just to add to that, I have added in the chat box. We fund a program called Connect and Thrive, which is a psychosocial program, and they do provide support to apply for the NDIS for psychosocial. But yeah, we have heard that it's becoming increasingly difficult to to have a successful application. But that service is available to support with that if need be.
Okay, we have one more question on Zupentixol. Um, Look, Zupentixol is quite effective with schizophrenia patients. Okay, I am quite happy with that. It does cause long-term akathisia or tardive dyskinesia. I do not fix what's not broken. If you know what I mean, if they are doing well, it's not a time to change the medication, just because we have lots of atypical antipsychotic medication available. Sometimes that can upset the apple cart. However, if you have patients who are struggling with the residual side effects, then you can change the medication to the typical antipsychotics, like paliperidone, for an example. Do it with a mental health team, to be honest, rather than in your busy GP practice. It needs to be quite planned. Needs to be quite planned. The one that asked about that question, what side effects have you noticed that you were concerned about with Zuclopentixol? So yes, so like I was mentioning, those with, like, for an example, clozapine with Zuclopentixol, trust me, if they did not need to be on both, they wouldn't. But if they are on clozapine plus a depot, it does show how unwell they can get with if they weren't on it. So extrapyramidal sedation, no motivation, you need to weigh it up with what happens if they are subtherapeutic. So I have patients, for an example, hearing relapsing to a point where without the clozapine or depot medication, they hear voices to kill themselves or kill others, for an example. So then we really need to weigh out the risk versus benefits. Unfortunately, there is there is no immediate fix. And sometimes trying to take or alter a medication like that can take months to recover from that. So we really need to be careful on how much of risk we want to take, and whether it is worth altering the medication. And whether for these sort of patients that are already seeing a psychiatrist or a local mental health team, because they need to see them at least once a week for the first 18 weeks and then once a month after that, whether that's a question or that's a whether that's a case that the specialist needs to answer, rather than a busy GP trying to alter the medication. It is a very high chance for the mental health patients to develop long-term neurocognitive disorders like dementia, whether it is because of the progression of the illness in itself. For an example, schizophrenia does have functional neural deterioration over time, and whether that causes dementia, or whether long-term antipsychotics does cause slowing of the neural activity and that causes dementia. uh, when the patient have dementia, we need to treat it dementia like. So if it's unfortunate and it happens before the age of 65, then they would need to be referred to the local mental health team, especially if they are not able to function and their loved ones or family members are not able to look after them. If it's over 65, it's quite straightforward, where we involve ACAT and things like that and try and put in some strategies or placements for them. But the ones who are mentally unwell, chronic mental health before the age of 65, it depends on how bad the dementia is, because dementia medications in itself can increase dopamine and can cause psychosis to be worse. So you wouldn't want to give patients dementia medication, especially the ones who are chronically mentally unwell, without a specialist involved. And how do we treat extrapyramidal side effects? Example, fine tremors. For those taking antipsychotics, propranolol and clonidine. Basically, yeah, low doses and work it up, and hope it doesn't work it up to a point where it doesn't affect their heart rate or blood pressure. Propranolol and clonidine are perfect for fine tremors. And dementia with patient with dementia and suspect underlying undiagnosed ADHD and autism, treating for quality of life. So that's a question that specialists will need to answer, because do they give stimulants for dementia and then risk the behavioral psychological symptoms of dementia, BPSD? Is something that the either psychiatrists or psychogeries or the geriatricians will need to figure out, because dementia in its own does have problems with concentration, focus, and forgetfulness. Not so much autism spectrum disorder. But once the patient has got dementia, it trumps all the other it trumps all the other illnesses. So that needs to be managed multidisciplinary with a specialist, because that's sort of like, you need to wonder how fast and how worse the dementia can progress, and what sort of supports they would need quickly.
I think that might be all our questions.
Thank you.
Yeah, thank
Hope that
you.
was useful.
Thank you. That was really helpful. Yeah, it was very practical advice. So thank you
So we
very
have
much.
one
Oh,
more.
we have one more.
Yes. I have a patient with ADHD, autism, depression, endometriosis with chronic pain. Yes, she's asking for a letter for. Well, I do tell patients that they will need to choose between medicinal cannabis or treating their ADHD with stimulant medication. Um, we I have patients that, I don't mind, a medicinal cannabis clinic, sort of. So you, instead of you recommending, you're a GP, you're actually asking for an opinion, is what you need to tell her, and say that, I am happy to write a referral to a medicinal cannabis clinic, and state that this is what you're on. But if you're on stimulant medication, your psychiatrist will need to sign it off, saying that you are okay for medicinal cannabis, which in Dokotela, no one is going to do that. So I always advocate for CBD preparation, CBD oil, if the patient is being treated with stimulant medication. And we need to address each of it separately, like ADHD and depression. Maybe being on a good stimulant medication can alleviate the ADHD and depression, that sometimes is a secondary to untreated ADHD. They are obviously going to be low in mood and anxious because they're not getting anything right and they're not completing any task. But once that is being sorted, the depression actually goes away. But if it still persists, then a bit of SSRI or SNRI. But if it still persists, then could it be past trauma that is still perpetuating this dysthymia? And whether they need to see a psychologist. Okay. And autism is the same as well. Where they're still having trouble socializing, or they're unable to read other people's cues, whether that really needs a developmental psychologist to help with that. Endometriosis, maybe refer to gynae, or if you are comfortable, many GPs just give some hormone therapy to thin the lining of the uterus. I'm a psychiatrist, but this is what I hear from my fellow colleagues and patients, where they get some hormonal therapy, and those with chronic pain, whether they will benefit from a bit of clonidine rather than medicinal cannabis. But if the patient is actually asking for a recommendation for medicinal cannabis, look, all you can do is to list all of this. But if she has a psychiatrist giving stimulants, then it is our duty to actually inform the psychiatrist that this is what she's after, so the psychiatrist can have a discussion with the patient on medicinal cannabis. But if, for an example, if you sent me a letter saying, by the way, this patient is looking for medicinal cannabis, I will be having a conversation with the patient saying that, why don't you try CBD oil, and have all of this addressed separately, biopsychosocial model, and then we revisit it again. So patient needing a mental health report for travel work cover, can it be done in the public system? It depends, because work cover is separate from the travel. Like work cover has its own work cover psychiatrist and work cover psychologist that would actually do all the paperwork. Um, if it's for mental health report for travel, so as in if they are needing to have their medications when they're traveling, um then you can just give a patient health summary, really, which is what many GP clinics does, where it just lists all the diagnoses and all the medication that the patient has. But yeah, the I don't think just for travel, public psychiatrist will see them, or work cover is a different it's a different department altogether, because work cover will have their own um psychiatrists and psychologists that will do a whole report for them, which we do in Dokotela.
Okay, we're just on time, so we might wrap it up there. But
Thank you
thank
so
you,
much,
Dr.
everyone.
Seth, and thanks everyone for their questions. It was a really engaging event. And just a reminder that the evaluation survey will pop up on your screen. So if you can please complete that so we can issue your certificate of attendance. That will be much appreciated. And enjoy the rest of your evening, everyone. Thank you.
Thank
Thanks,
you
Dr.
so much.
Seth.
All the best, guys.